Our next speaker for this evening, if I may, just give me 1 second, is one of our research committee members. Now, this person is on the St. George Sutherland Medical Research Foundation Research Committee, a conjoint associate professor at St. George and Sutherland Clinical School, a clinical specialist, speech pathology, UNSW medicine as well, and I hear that she just told me that she's going to Beijing next week to share the results of her research, and that's what good bilateral relations are about. So ladies and gentlemen, can we put our hands together for Dr. Julia Maclean?
Thank you very much. I'd like to thank the organisers for inviting me to talk this evening. Scott just gave me a quick lesson because I am off to Beijing next week, and so this is unfortunately the extent of my language skills. Ni hao, xie xie. We're changing pace a little bit. I would like to talk to you a little bit about research and why clinical research is important to our hospitals and also our community. So I've worked at St. George Hospital as the senior speech pathologist in ear, nose and throat surgery and oncology for the past 23 years. And I'm just going to spend a little bit of time reflecting on some of the research activity that we've done and what we're doing and how it's made a difference to our patients and our community. Early in my career at St. George, I was very fortunate to come into contact with Professor Ian Cook, who's a gastroenterologist. He was one of the founding members of the St. George and Sutherland Medical Research Foundation. And Professor Cook has taught me the value of being a clinical researcher. People were asking me, I think when we think about researchers, we think about it happening in academic units, in universities, and researchers being in a lab with little petri dishes. But for many of us, it's actually happening in hospitals with our patients. And these clinical researchers, we can make direct impacts on our patients. So I want to challenge that notion about research just happening in universities, and I want to discuss when patients and when we blend the two, so we actually have clinical researchers working in hospitals, that we can concentrate on making the sick better, but we can also concentrate on the very important research that we have to do. So we actually have very good evidence that hospitals conducting basic and clinical research are more efficient. They have reduced healthcare costs and better health outcomes. We actually diagnose more quickly and more accurately. We provide the best treatment for patients, and the surgical outcomes for those patients are better. And there's also a shorter length of stay, which is a real push for everyone in hospitals. Typically, research that is published in the journals takes 17 years to come into clinical practice. So what's really important when we're doing clinical research is that we can translate our findings directly with our patients. So it allows prompt translation of research into practice. It also gets clinicians to think critically. It gets them to ask and answer questions and evaluate outcomes. And those three things are actually research. And we know that research improves patient care. So in terms of relevance and importance to the community, research discovers important new healthcare advances. It ensures a rigorous approach to assessment. We have to evaluate everything that we do. And really importantly, people want to be at the cutting edge of what's going on, so it attracts good people to the institution. It creates stable clinical teams retaining key staff. For myself, because I've been involved with research so long and we're embedded in a research program, we stay at the hospital and we continue to work and build on our research. And we know that good people in the right environment equal an excellent healthcare system. So I'm going to talk to you about something this evening which I think illustrates this, and it's something that I research, which is swallowing. And it's something that, using tonight's slogan, I really care about. Swallowing is something that we don't put much thought into, but it's really fundamental to life. As I say to my patients, it's something that you don't think about until you can't do, and then it's often all you can think about. Swallowing is central to our quality of life. Look at us here tonight, we meet amongst a meal, and that's what happens with our friends and our families. We go out, we drink coffees, and we eat together. Swallowing disorders are actually very common in many conditions. In fact, 1 in 17 people will develop a swallowing disorder in their lifetime. Neurological disorders, cancer and its treatment, and ageing are all some of the reasons that people get swallowing problems. We know that 27% of people over the age of 76 will have difficulty swallowing, and 51% of people in our nursing homes have difficulty eating and drinking. 50 to 75% of stroke patients, and the area that I work in, 60 to 70 patients who we treat with head and neck radiotherapy and we cure them of their cancer are left with significant swallowing problems. We actually know that there can be potentially catastrophic consequences from these difficulties in swallowing. People can be malnourished, it can have a direct impact on their quality of life, it can result in pneumonia and death. We actually have done research that has shown that 30% of non-cancer related mortality in our population is because patients cannot swallow. 65% of the patients who I treat will have swallowing difficulties. So I'm going to just give you a quick lesson in swallowing. This is a patient swallowing. You can see the black going down as he swallows. It's an X-ray, that's barium, and this is a normal swallow. So all of that happened in less than 1.5 seconds. Okay, that's normal swallowing. It takes 30 muscles to get something from the mouth to the top of your esophagus, and it's a highly coordinated activity. We do it 1,200 times a day. This is a patient who's had head and neck cancer treatment. You can see the hardware that's in his jaw, and as he swallows, if you look at the black going down the front, that is actually going down into his lungs. And you can see that the black that is in his pharynx, or the area at the back, is really sitting there. It's not squeezing down into the esophagus. Swallowing is really hard work for this man. So I'm just going to tell you a little bit about a current research project that we're doing, and this has been supported by the St George and Sutherland Medical Research Foundation. As I said, we know that lots of our patients have food and liquid going down the wrong way, and up until now we've had great difficulty in quantifying that and knowing which patients are going to fall into trouble. So we're using new technology. We're using a special test in nuclear medicine where we use a single proton CT scan, and the patient swallows a certain material, and then we use a 3D camera, and we can accurately detect and quantify how much has gone down the wrong way into the lungs. So you can see here the red that you can see lit up is actually where liquid has gone down the wrong way, and for the first time we can really quantify the amount that's sitting in the lungs. We can also assess, importantly, which patients are able to clear this, because if something goes down and you can clear it, you're not going to end up with the same serious consequences. So we have a research program where we have patients who we know have things going into their lungs, and we're using expiratory muscle strength training. And this is a simple breathing device where we actually decrease the lung complications by getting the patients to improve their lung strength and their cough. So you can see someone being trained in EMST here. Really importantly, it's easy, it's cheap, and it's effective. So if we find that we can do this, this will be our holy grail that we've been working for over 15 years to find. We will be able to see who is really at risk of developing these aspiration-related consequences. We might be able to identify them early and do something before they're in trouble. And we might be able to change the risk that they have. If we can put them in exercise programs with physio, we may be able to strengthen that respiratory response using this simple device that patients can use at home. And if you think about me saying that 1 in 17 people have swallowing disorders, you can imagine how we can apply this knowledge to a really, really wide range of people. I'm just going to finish talking to you about this patient who you can see sitting in the back with his family there. Peter is a patient of mine, and he's very happy for me to tell his story. Peter was a fireman. He was a local fireman, and 3 years ago he developed a head and neck cancer. He actually sailed through treatment. He came in every day for 35 treatments or 7 weeks and had radiotherapy, and he had chemotherapy each week of his treatment. At the end of his treatment, things started to fall apart a little bit for Peter, and he was unable to swallow, and it got to the point that he couldn't swallow anything at all. In fact, his esophagus completely closed, and we had to systematically, with our gastroenterology colleagues, open up his esophagus for him. At that time, a lot of the material he swallowed went into his lungs. He actually had 4 admissions to our intensive care unit. He arrested at home. His wife had to give him CPR. And this was because food and liquid was going down into his lungs. We've been able to work with Peter. We've trained him. We've got his expiratory muscle strengthened and improved his cough. And I'm really pleased to say for the last 12 months he has stayed out of our intensive care unit. Last week he went away with his family for the first time. And you can see him sitting there with his 3 daughters and his grandchildren who he didn't think he was going to be around to see. And I can tell you, although life is still really hard for Peter, he's mainly fed through a tube. He has a drink every night with his family. And he would certainly tell you that his quality of life has been directly impacted on by the research that we've done. So ladies and gentlemen, this is an example of where research can directly impact on the lives of our patients that I treat every day. My research subjects are the patients I see daily. The interventions are able to be conducted throughout their standard treatments. They are aware that they're participating in research and that we're evaluating their outcomes. In my experience, patients love being part of research. They know that it might help them, but what they really like is they know that it will actually impact positively on the next generation of patients coming through. Research allows us to systematically assess the outcomes of our interventions, and when we make breakthroughs, we can implement them directly into our treatment paradigms. It doesn't take us 17 years to get our research into practice. So in my experience, research conducted in teaching hospitals can make a positive impact on the patients we treat. Really importantly though, it provides a dynamic and positive work environment for clinicians, encouraging us to do better for the patients that we are there to serve. Thank you.